Good morning, everyone. Hope you all are doing well. Thank you so much for logging in a little bit early. If you don't mind opening up your chat box, saying hello where you are logging in from. Looking very forward to this session today. It's a unique session, so very excited. Thank you again for joining, and feel free to open up your chat box, say hello. We're going to get started in just about 8 to 10 minutes. All right. Good morning, everyone. If you are just joining us, welcome, welcome. I see we have people already in the chat box, super excited for today's session. If you don't mind, just as a quick little audio check, if you can hear me and see me, do you mind just typing in yes into the chat box, please? Excellent. And if you're just joining us and you have not just yet said hello in the chat box, go ahead and open up your chat, say hello where you are logging in from. I want everybody to utilize the chat box feature throughout today's session. And if you're joining on YouTube or if you're watching this recording at another time, welcome. Make sure you also are staying active and engaged. And today, over the next hour and a half, it's going to be some fun stuff coming at you. Excellent. How many of you all are taking Step 2 CK within 4 weeks from now? All right. Padmini, Shagun, Sydney, Alexander, Mansi. Wow. Amazing. Many, many students. I know applications and ERAS is coming up. That is excellent. I'm so excited we could do this quick, rapid review. And I'm going to try to sneak in a few more as we continue to prepare for both Step 1 and Step 2. But today is going to be really focused on Step 2. So we're going to get started in about 2 minutes. Make sure you have your sparkling water. I had a Instagram post where somebody tagged me that they're at Starbucks and they are logging in from the session for the session. So I want to ask you guys, as we are getting warmed up here, where is your favorite place to study? Where is your favorite place to study? Are you a library person? Like to study at home? Other locations? Okay. Awesome. Library. Yeah. Okay. Home. Some people are saying cafe. Awesome. Yeah, I was quite the library studier. However, I would oscillate because there's no place like home, but sometimes I can get distracted, especially when family and friends are around. So excellent. I know any place with air conditioning, it is very hot in many parts of the world. So excellent. Well, thank you all for sharing. If you're just logging in on YouTube, appreciate you all joining. And if you guys are able to and know somebody, some of your colleagues who are preparing for the exam and want to share on your Instagram story or TikTok or anything, the live link from our session, feel free. I just put it into the chat box right here. We're going to just give it one more minute for people to join in. We have about 150 people joining us right now. Feel free to share the live link here. Awesome. And if you have not yet said hello in the chat box and where you are logging in from, as well as maybe even your favorite study place, feel free to do so now. We have Rogelio from Florida, Katie from Florida as well. I was just in Brickell a couple of months ago. That's fun. Hello, Amrita. And if you are just logging in or have logged in, feel free to change your chat box feature to say everyone rather than just hosts and panelists. Just toggle that and hit everyone. That will be very helpful for you as we prepare for today. All right, let me go ahead and clear some of my screens here. Wonderful. Well, it is 10 a.m. Eastern Standard Time, and I am Zooming with you all from a new place. I just moved. I'm super excited. And today is a very special Step 2 CK webinar. Before we get started in today's webinar, I want you all to stay active and engaged. This is going to be a breakdown of the free 120 questions in a unique way. They're not going to be the exact same questions. They're going to be the similar concepts. So if you haven't taken the new free 120 just yet, don't worry. This session is still going to be very high yield. Hey, you're going to have to review and get assessed on those concepts at some time. Biggest thing for the next 1 hour and 15 minutes, maybe even hour and a half. Please cut out distractions. What I want to do here is to create an active learning environment so that all of us, imagine you're in a classroom of around 175 people right now. Cut out distractions, put your phone away, turn off those tabs. I am just so grateful that you are here joining me today, right now. Let's get pumped for this session. So this is block 1 of the new free 120. This is the free 120 that is the 2019-2020 PDF that is freely accessible on the USMLE website. If you have not joined one of my webinars just yet, my name is Rahul. I am a practicing pediatric critical care physician. I recently graduated from University of Pennsylvania. I got my master's in medical education. I'm a med ed nerd. I even put hashtags on my slides. But over the past 7 years, I have been absolutely passionate about helping students excel and prepare for the USMLE Step 1 and Step 2 CK. I have a unique lens on how I like to teach this material and help you prepare. Not only is it high energy, but it focuses a lot on active recall, integration, and for Step 2 in particular, it is clinical reasoning based as well. So thank you all for your love and support in the chat box. That is so wonderful, and I'm so thankful to each and every one of you. So before we get started, I just wanted to spend a few minutes on what makes HyGuru so unique. I think that HyGuru is your active learning solution. I focus a lot for Step 2 CK on vignette learning. We're going to be going through 40 vignettes today. I focus a lot on clinical reasoning, what you should be thinking about, not only for your exam, but for your rotations, residency, and beyond. I focus on linking concepts together. And in particular, I love putting in some basic science integrations as well. How many of you all have utilized my pass-fail program or have watched my NBME Top Concepts or Step 1 playlist before? A lot of basic science here. Yeah, Isabella has. Amberly. Okay, wonderful, wonderful. I know the Step 1 area is where I started. And about a year ago, I also started incorporating with Step 1, Step 2. So now I'm doing a lot more of both. I also focus on test taking strategy, and not so much like buzzword or gamifying or kind of like weird, cheap tricks, truly making you understand that there are pertinent positives in the vignette you need to clue in on. And those end up being patterns over and over again as these questions are written. And then finally, I recognize and understand that this is quite the grind. And that's why I really like to focus on test taking psychology. This whole journey of medicine is a lifelong learning process. And I want each and every one of you to stay inspired, stay engaged. This is not just for your exam, guys. This is to kick ass in residency, fellowship, and beyond. And I'm so grateful that I have the opportunity to continue to be at the bedside with patients, even though the long call nights are hashtag a grind. So, all right. Well, when I am working with medical schools, and if you have a medical school and you want to kind of see if we are a right fit, so to say, talking to your administrators, recognize that this is the triad that I focus on: integrating content, clinical reasoning, making sure we have peak test taking psychology, and make sure that you have a damn good study schedule that is rooted in questions. And that's where I like to utilize Notion. I have a really popular video that goes through how to review UWorld efficiently and effectively. So I would encourage you to check that out as well. Most importantly, as we all log in here today, all 200 of us, HyGuru is a true family. It's a global community of lifelong learners in medicine. And I have been absolutely grateful to connect with so many students from all different continents, not Antarctica just yet, but more importantly, I'm super grateful to have you all here today. And we are going to absolutely crush it. Special announcement, especially if you are studying in dedicated study, I have just updated my Step 2 CK shelf rapid review resource. Goes through all the clerkships as well as some of the key points I emphasize in one-on-one tutoring. It is 30 hours. You do your CMS forms and UWorld questions during the day and pivot into this course in the afternoon to get that comprehensive active recall vignette-based learning. I highly encourage you to check out HyGuru.com and feel free to sign up and even ask me any questions that you have prior to signing up. This has been quite the journey for me. As you can see in the past 2 years or so, these are some of the students that have reached out to me personally, updating me on their scores. And this has been absolutely great to see. And remember, it's not about the 3-digit score, even though that is important. It's about your growth throughout this process. All right. That is the introduction. I hope you all are still here, active and engaged. I want to, without any further ado, go through what we are going to be going through today. And that is understanding the free 120 concepts. So as you all know, for step 2 CK, there are 3 free 120s. There's the old free 120 that was back in 2018, updated in 2019, the new free 120, which is the concepts that we are going to be going through today, and then the interactive free 120. This is the one you can also take on the Prometric or at the Prometric site. By paying a small fee, you can actually do a quick little practice session with Prometric, or you can take it online. I have published some explanations on my website. It's under resources, free resources. So feel free to check that out if you would like to go through the text explanations of the new free 120. So how did I organize this webinar? Well, I didn't just want to go through the whole PDF and read through every single sentence. One of the things that I really enjoy is taking a lot of information and just putting it down into the need-know information and how to think about it. So today what we're going to be doing is we're going to be going through the paraphrase vignette. I'm going to be focusing a lot on the illness script of how to recognize diseases and what are the focal points of assessment. What we're going to be doing is we're going to be going through the shortened paraphrased vignette. I'm going to be going through the focal point of assessment, the correct answer at some intervals. That's why I want you all to stay active and engaged. At some intervals, I'm going to ask you all to participate and put in your answer. But as we go through this, I want you all to recognize some of these diagnoses or illness scripts. And what we will do after we reveal the right answer is I will go through why some of the more popular answers, if you're down to 2, how to differentiate them. And that's going to be very important. What else I'm going to be doing is I'm going to be doing my signature Khan Academy style chalk talks, where I'm going to be explaining for many of these questions the pathophysiology in a story. This is going to really derail those of you who just keep smashing the space bar with Anki. It's great. It's fine. However, remember, the goal is to understand the mechanisms behind the disease, because your patients are not flashcards. Your patients have their own narratives internally, what's going on with their pathophysiologic state inside of their body, as well as their beautiful narrative that makes them the individual that they are. One of the key things that I want you all to recognize is that many of these USMLE questions have this same cadence, where they go into and start with the chief complaint, followed by elaborating on the chief complaint, the past medical history, which makes the patient very rich in terms of the patient demographics. This is part of their own story. And then eventually you get into the doctor's perspective, where you're going through more objective data, vital signs, physical exam, labs, imaging, etc. So this is very important for us to note, because this organization will allow for us to package illness scripts in an organized manner. And when you feed your mind in a logical and organized manner, your output is also going to be very systematic. And that's key for us to know. So whenever you get a question that is, what is the most likely diagnosis? I think about, in this first block, about 12 of these questions are, what is the most likely diagnosis? Very popular STEM for step 2 CK. The goal is for you to recognize that they are making you activate an illness script. And what is an illness script? It is a mental representation of the disease. An illness script is a mental representation of a disease. So what I mean by that is, let's say that there is a vocab word. A vocab word always has a definition. So let's say that the definition here that I'm giving you is the heart is not contracting as well. Blood is backing up into the left atrium and into the lungs, causing a patient to have crackles. What illness script am I highlighting right there? I gave you a pathophysiologic story. What is the illness script that I am going for here? Absolutely. If you're listening, you will be understanding this or getting this right. And the answer is yes, you got it. Congestive heart failure. So the point is that an illness script is activated when you understand the mechanism of disease and say, oh, wait, that's the vocab word that we talk about in medicine related to that story you just brought up. So typically the word or the words or the phrase that sounds like X is when you activate an illness script. Oh, I'm reading a question. Oh, that sounds like congestive heart failure. When you say that sounds like, that is activation of an illness script. So let's go through some illness script rapid fire here. What if I had a patient on your USMLE, chest pain, diaphoresis, has EKG abnormalities and positive troponins? What is the illness script that you're activating here? Excellent. Starting off a little bit easier, acute coronary syndrome or myocardial infarction. What about this illness script? A patient with acute chest pain radiating to the back, has widened mediastinum on X-ray. Absolutely. Aortic dissection. You know, one of the things for us to recognize is that there are sometimes overlaps related to illness scripts. Widened mediastinum, your differential can be anything from thymoma, lymphomas, all the way to even Boerhaave syndrome, where you have rupture of the esophagus. So what you want to understand is not only how to recognize illness scripts, but more so how to differentiate between illness scripts. And that's super high yield because when you are going to be answering USMLE questions, there are going to be some answer choices that are not like tricks. No, they just want you to differentiate the illness scripts between aortic dissection and Boerhaave syndrome. And that's where you look at a lot of the data points. And if majority of the data points suggest that the patient has atherosclerotic risk factors, is going to have maybe a history of Marfan syndrome, is going to have a severe hypertension, and has this chest pain radiating to the back with widened mediastinum, more so the data points are aligned towards acute aortic dissection rather than Boerhaave syndrome. Fever, purulent sputum, dullness to percussion in unilateral lung fields with focal crackles. Everybody is saying pneumonia. Yep, absolutely. Remember that if you are going to have pneumonia on the right side, you may also want to look at the patient's past medical history or demographics to make sure you are not dealing with a aspiration pneumonia, and that's super important. How about this one? History of surgery, abdominal pain, distension, air fluid levels on KUB. If you're saying small bowel obstruction, you are absolutely correct. Remember, the history of surgery predisposes this patient to adhesions. Finally, gradual onset or chronic progressive onset of memory loss and decline in activities of daily living. If you're saying Alzheimer's disease, you're absolutely correct. So again, the goal here is for us to take long vignettes and paraphrase them, creating broad brush strokes such that if they say, for example, that the patient does not go grocery shopping anymore, that in your mind should then be paraphrased as decline in activities of daily living. And then the next step in your thought process should be, what are some of the things that can cause, what are the vocab words or illness scripts that have decline in activities of daily living as a sentinel feature? Things such as, for example, psychosis, schizophrenia type of diseases, severe depression, and yes, you got it, some sort of long-standing neurodegenerative process such as dementia. So I hope you guys have now understood and recognized the power of illness scripts. And so at the end, we're going to be going through how you can make your own illness scripts, but typically focusing on the tempo of disease is going to be your biggest start. Is you want to understand whether a disease is more acute, less than 2 weeks, subacute 2 to 4 weeks, or chronic. And again, recognizing that an illness script is a mental representation of the disease. And that is exactly how I have rewritten all of these concepts and questions. Again, I do not want to just show up with the PDF. We would be here for hours and hours just going line by line by line. There are other resources that do that. I want to make it very focal, integrated, and with every single question, I'm going to ask you a just step beyond question to kind of push your active recall, which is going to be super fun and awesome. All right, so with that, I'm going to take a little bit of a pause. I am going to ask you all and invite you all to open up your chat box and answer this question. Are you all ready to go? Ready to fire up this block of questions? I hope that this is going to be a lot of fun for you all. Carissa is fired. All right, I love it. People are fired up. And if you have not participated just yet, go ahead and do so because it's worth it. Cut out all distractions and let go with the first question. Here we go. Which of the following is the most likely to improve this patient's cognition and movement? We have subacute progressive lethargy and tremors in an elderly patient with severe alcoholism who now presents with somnolence, postural tremor, and loss of muscle strength. Which of the following is most likely to improve this patient's cognition and movement? What do you think is the best answer? A, antibiotics, B, thiamine supplementation, C, oral lactulose, or D, oral lorazepam? What is going to be the best answer here? All right, a lot of different answers here. Excellent work here. Recognizing that if the patient has subacute progressive lethargy and tremors, what you are going to be thinking of is that this patient is most likely with the CNS depression in a subacute standpoint has hyperammonemia. So ammonia is going to be very high. The patient is also very somnolent. Remember that NH3 is going to build up, cross the blood-brain barrier, deposit in the basal ganglia, and that causes you to have the tremor that we call asterixis. It also is going to cause poor movement and inability to control your small movements, and that's why you get this loss of muscle strength. Another thing that patients with hyperammonemia are going to have is they're going to have confusion or lethargy. They may even at times have agitation, but once your ammonia level goes above 200, you become a lot more somnolent. You can get a respiratory acidosis as a result due to hypoventilation, and these patients can also have seizures as well due to the glutamate excitotoxicity. So the best answer here is going to be C, oral lactulose. And remember that oral lactulose is going to take your ammonia and turn it into ammonium. So alcohol is going to affect the liver, and you are going to have poor conversion of nitrogenous waste to urea. If you don't have the urea cycle because of hepatocellular damage, that is going to build up, cross the CNS, and give you these symptomatologies. So hopefully this allows for you to recognize the illness script of hyperammonemia. And again, the focal point of assessment here is that we use oral lactulose. All right, let's go through this next question. I'll have you all put in the answer into the chat box as well. Which of the following is the most appropriate next step in diagnosis? We have acute, progressive, shortness of breath, cough, and fever in a middle-aged woman with asthma who now presents with fever, tachycardia, tachypnea, and hypertension with exam, notable for unilateral crackles, diffuse wheezing, and unilateral sensory neuropathy. Which of the following is the most appropriate next step in diagnosis? Why don't we break this down right now and first just ask, what is the diagnosis? Go ahead and put that into the chat box before we go into the answer choices. What is the most likely diagnosis in this patient who has asthma, signs of pneumonia, hypertension, and neuropathy. Okay, got many different answers here. Let's go through some of the key illness scripts. In this patient, you have the neuropathy, you have the pneumonia, you have the hypertension, and characteristically, the patient also has a past medical history of asthma. So whenever you are thinking of multi-system involvement, many organ systems, the first thing that you should be thinking of is, man, this is going to be some disorder that affects many different organ systems. And one of the key diagnostic consideration is this a vasculitis? So this vasculitis associated with asthma, eosinophilia is eosinophilic granulomatosis with polyangiitis, formerly known as Churg-Strauss syndrome. Remember that this is going to be a hemoptysis, i.e. affecting the lungs, and hematuria syndrome. And just to tie in step one, we recognize that eosinophilic granulomatosis with polyangiitis is associated with P. ANCA and also has necrotizing granulomas associated with it as well. So the best answer here is going to be, you got it, F, serum ANCA assay. Recognize that CT angiography, that definitely is going to be the answer for a PE, but typically PEs don't have fever. Determination of serum ACE concentration, that's going to be sarcoidosis. Yes, sarcoidosis can give you pulmonary symptoms, but usually in this situation, it's not going to give you a asthma, hypertension, and sensory neuropathy type of phenotype. Remember that serum IgE concentration just means that the patient is atopic. Mesenteric angiography, typically this is for microscopic polyangiitis or polyarthritis nodosa. These are going to be visceral vasculitides. Also recognizing and understanding that microscopic polyangiitis is also P. ANCA positive. Serum anti-GBM, that is going to be your formerly known as Goodpasture syndrome. Sweat chloride testing is going to be related to cystic fibrosis. So remember that if you wanted to make a little bit of a riddle or a song, C. ANCA is Wegener's or granulomatosis with polyangiitis. The key in that illness script is a sinusitis, whereas asthma, eosinophilia, and signs of a vasculitis, that's Churg-Strauss, and that's called EOGPA. And that's not C. ANCA. That is going to be P. ANCA. And P. ANCA is positive for myeloperoxidase. Very high yield for us to know there. All right. So far, so good. Everybody enjoying this? This is a little bit of a preview. We've slammed through about 3 questions. You guys doing okay? Okay, wonderful. Let's keep going. Which of the following is going to be the most likely diagnosis? Here we go. We have acute on chronic severe abdominal pain and inability to void in an elderly multiparous woman with history of mastectomy, osteoporosis, controlled on alendronate, who presents with cervix protruding from the vagina and an elevated post-void residual. What is the illness script here? I.e., what is the likely diagnosis? A, overactive bladder. B, overflow incontinence. C, stress incontinence. D, urinary retention. Or E, urinary tract infection. What is the likely diagnosis here? I'm going to pause for a little bit. Excellent. And the best answer here is going to be urinary retention. Remember that the patient has an inability to void. That does not mean that they are incontinent. So overflow incontinence usually presents with a dribbling of urine, or they are essentially going to have a chronic or subacute wetting themselves type of illness script. Also, I just wanted to put here that the multiparous nature means that the patient is going to have a little bit more ligamentous laxity in the reproductive region. And then that leads to cervical prolapse or even uterine prolapse if everything is kind of protruding out there. And that then can cause bladder obstruction and subsequently is going to allow for you to not have full emptying of the bladder itself. What is the mechanism of action of alendronate? This is going to be a bisphosphonate. It is an osteoclast inhibitor used for osteoporosis. And let's say on the USMLE, they say the patient has osteoporosis controlled on alendronate, and suddenly they have acute severe jaw pain. They're going for osteonecrosis of the jaw, which is a common side effect. And then what if they say that the patient is on alendronate and they come in with cough and difficulty swallowing? You want to be thinking of eosinophilic esophagitis, and that is extremely high yield for you to know. Remember that the classes of medication that we use for overactive bladder, that is going to be oxybutynin, antimuscarinics. You can also use mirabegron. Mirabegron is going to be a beta-3 agonist that is going to allow for you to have less spasticity of your bladder. Stress incontinence, the USMLE loves for you to know that it is urethral hypermobility. That is a pathophysiologic mechanism. And again, any sort of increase in intra-abdominal pressure is going to make you pee in stress incontinence. Very good. Ripping through these vignettes. Let's go through this one. Which of the following is the most likely cause of this patient's hematologic abnormalities? We have acute fever, dizziness, lightheadedness, chills, and shaking in a young military recruit with history of hyperthyroidism controlled on methimazole, who now presents with fever, tachycardia, tachypnea, hypotension, and leukopenia. Which of the following is the most likely cause of this patient's hematologic abnormality? Is it atovaquone proguanil, fluticasone, hepatitis A, methimazole, or omeprazole? Excellent. If you are saying that this is going to be methimazole, you are absolutely correct. Let's go through this very important illness script. What we notice here is that the patient has acute infectious symptoms, and anytime you see fever, hypotension, tachycardia, you have to tell yourself that that is septic shock. Now, in this case, the patient has a medication that predisposes him to infection. Methimazole, remember, is going to block thyroid peroxidase, and that's why it's going to be good for hyperthyroidism. However, methimazole, similar to clozapine, for example, can cause leukopenia, and that leukopenia then predisposes you to infection. So leukopenia makes you immunocompromised and thus predisposed to infection, and that's why the patient has septic shock. And how do you recognize septic shock? Fever, hypotension, and tachycardia in your vignettes. And they usually tell you to interpret the numbers. But again, you're noticing the theme here is that paraphrasing is critically analyzing the data points within the vignette itself. So next best step in management, well, yes, you're going to stop the methimazole, but this patient is actively dying in front of you. So IV antibiotics, you're going to start giving crystalloid fluids with normal saline or LR, and think about starting vasoactives such as norepinephrine to treat the shock itself. All right, let's go through this question. Which of the following is most likely to have prevented this patient's current condition? We have acute headache, fever, lethargy in a young, unimmunized college student who was exposed to a sick contact. This patient now presents with fever, tachycardia, hypotension, #septic shock, and physical exam notable for diffuse purpuric rash and nuchal rigidity. Which of the following is most likely to have prevented this patient's current condition? Before you put in the answer, can you tell me a little bit about what is the diagnosis? What is the illness script here that was activated? Many of you say, that sounds like, anytime you see that sounds like, you have activated an illness script. That is where your content knowledge has assimilated to the point where the external stimuli, which is the question, has prompted some application of content knowledge. And you're absolutely correct that this is meningococcemia due to a very important agent, and that is going to be, yes, you got it, Neisseria meningitidis. So remember that Neisseria meningitidis, just for a microbiology tie-in, is going to be a gram-negative diplococci. The signs of septic shock could be because of the fact that the gram-negative diplococci has lipopolysaccharide, and that causes an upregulation of IL-1, IL-6, and TNF-alpha, and that then reduces your systemic vascular resistance, and thus that's why you have fever, hypotension, and tachycardia in your vignette. Another etiology of the fever, tachycardia, and hypotension could be due to adrenal insufficiency. And that adrenal insufficiency is going to be known as Waterhouse-Friderichsen syndrome, in which you get acute hemorrhage of the adrenal glands. And thus you have particularly no aldosterone, no cortisol, and no norepinephrine and epinephrine, because your adrenal medulla, along with your cortex, is going to be out and infarcted. So what is high yield for us to know here is that Neisseria meningitidis, we are going to immunize patients typically around the age of 11 and 16, especially if they are going to be in close contacts. And that is going to be the best answer to the STEM. What could have prevented this condition? And that is immunization. Remember that the vaccine, the Neisseria meningitidis vaccine, is going to be a subunit vaccine. And this subunit vaccine covers ACWY. And then we also have something called MenB, which is also given to teenagers. All right, moving forward here. Testing for which of the following infectious conditions is the most appropriate recommendation for this patient? We have an evaluation of first prenatal visit after positive home pregnancy test in a young, premagravid, previously healthy woman with 5 lifetime sexual partners who now presents with a routine uterus consistent with 10-week gestation. Congratulations, you have a new addition to the family. Testing for which of the following is most appropriate? A, bacterial vaginosis, CMV, EBV, HIV, or HPV. What do you think is the best answer here? Very good. So this is basically assessing you on the fact that when you have a first pregnancy visit, what do you want to be thinking of? You want to be thinking of screening for infections. And so one of the infections, especially if the patient has been having multiple lifetime partners, is going to be HIV. Recall that there are NBME and UWorld questions that test you on the fact that when we have pregnant patients with HIV and a high viral load, those pregnant patients are going to get HAART therapy, which is highly active retroviral therapy, to prevent vertical transmission. What is also high yield for us to know is at this visit, among other things, you want to get a blood type and Rh status. And the reason why is if the mom is going to be Rh negative, you want to provide that mother in the second trimester RhoGAM, and that's super high yield for you to know. All right, little bit of a ethics question. Which of the following represents the most appropriate next step by this study participant? So we have a research study involving a series of middle-aged to elderly adults with risk factors of diabetes who are consented and enrolled in a study following a regular exercise program. One participant requests to drop out 1 month into the study. What is the next step? Complete the study, discuss withdrawal with IRB, negotiate her withdrawal with the PI, wait to withdraw until after the investigator consults with the ethics team, or withdraw from the study right away. Absolutely. This is related to research ethics and making sure that you recognize that these types of patients have the autonomy to unenroll from a study whenever they would like. And that's very high yield for you to know. And also there's a biostats integration here. Typically what you want to do if there is going to be increased amounts of attrition or dropout from the study, the USMLE wants you to know that in your analysis, you will do intention to treat, essentially analyzing the data based on the original intention or the original group that the patient was stratified in at the onset of study. And so intention to treat analysis is highly tested, especially if you have multiple dropouts from a study. I'm going to pause right here. We are just about halfway. You all doing okay? Yes, no, maybe so. Kavya is. Excellent. Meher, Divya. Awesome. Coffee is helping. Okay, I hope my energy is helping as well, right? No? Okay, no good. That's okay. All right, very good. Thank you guys so much for staying so active and engaged. I really appreciate all of your guys' attention through this. And I hope you're learning a lot from these integrations. I tried to be very mindful of what are the key NBME points that I want to isolate for you all as a jump from these questions. So that's great. Which of the following is the most appropriate next best step in management? We have acute fatigue, oliguria, dysuria, and dark urine in an elderly male with history of gout, hypertension, and osteoarthritis. This patient now presents with mild fever, hypertension, and tachypnea. Which of the following is the most appropriate next best step in management? A, discontinuation of acetaminophen, IV fluids, measurement of post-void residual, oral Bactrim therapy, or E, renal biopsy. What is the best answer here in this patient? Excellent. If you are going to be saying measurement of post-void residual, you are absolutely correct. So let's go through and break down this question. The patient has acute oliguria. Oliguria means what? That they are going to have some issue with their urinary system. Either they have acute kidney injury, either they are going to have obstruction of the ureter, let's say they have a kidney stone, or they are going to have obstruction of the bladder. As a result of any change in the urinary system, RAS can go up. And if RAS can go up, that's why the patient is going to be hypertensive. Well, if the patient is going to have this acute oliguria and you're worried about the fact that this patient is unfortunately having an issue with their urinary system, you don't want to give too many fluids. In fact, in acute kidney injury in particular, you want to reduce the amount of fluid. So that's why B is incorrect. What you're noticing here, though, is that the patient is going to have potentially a uric acid stone causing some sort of nephropathy, could have a calcium-based kidney stone. Again, this is where the dark urine comes in. Remember that any sort of hematuria that you can have with flank pain, one of the differentials to consider is nephrolithiasis. But you could also have a outlet issue, i.e. a bladder outlet issue, in which you are going to have a very distended bladder. You get the fever because you're retaining a lot of urine. You get also the tachypnea because when you are retaining a lot of urine, you are going to be feeling uncomfortable, and that's going to cause you to breathe very fast. So in this situation, the best next step is going to be measure the post-void residual. And like we saw in our last question prior to this, or a few questions ago, the USMLE loves for you to know acute urinary obstruction syndromes. And whether that is going to be from a repro angle or a BPH or some sort of bladder outlet obstruction angle, just very high yield for you to recognize this type of illness script. All right, let's go through this. Which of the following is the most appropriate pharmacotherapy? Acute severe pain and decreased range of motion in the unilateral elbow in a middle-aged female with history of severe rheumatoid arthritis, controlled on methotrexate, hydroxychloroquine, and prednisone, who now presents with fever, decreased range of motion in small upper extremity joints, and signs of inflammation in the right elbow, with the fine needle aspiration of the right elbow, noting severe leukocytosis. Which of the following is the most appropriate pharmacotherapy? We have a rheumatoid arthritis patient who basically has a unilateral hot elbow with severe leukocytosis. I like how, Isabella, you activated the illness script and then you said, how do I modulate or reverse this pathology? I need to give vancomycin. IV antibiotic therapy is so important in this situation. Remember that this patient is going to be, you got it, immunocompromised. Why is that? Because prednisone causes you to be in an immunocompromised state. These DMARDs are going to decrease the amount of folate. If you have less folate, that means that you are going to have less neutrophils, for example, or less immune cells. And that less immune cells is good because then you don't get the hot inflammation of rheumatoid arthritis, but it can also predispose you for infections as well. And that's super high yield for us to know. Now, remember that if the patient has rheumatoid arthritis and is immunosuppressed and you have a severe leukocytosis greater than 30,000, it's not going to be gout. So no need to give things such as colchicine or ketorolac. You want to 110% first cover for septic arthritis or a septic joint because time is money there. And so vancomycin is going to be your best answer here. Remember that it's a gram-positive cocci in clusters. Typically, that is the most likely organism, which is MRSA or Staph aureus. Pick your du jour of gram-positive bacteria. Other things for us to note is the fact that if you are going to have diffuse arthralgias, that could be a flare of rheumatoid arthritis, and that's where you would do methylpred, and that's a flare of rheumatoid arthritis, but this is an infection. Remember that infliximab can also make you immunocompromised because infliximab is a TNF-alpha inhibitor. And one of the key exam questions that they want you to know is the fact that if you do start infliximab, or if you're going to be starting infliximab, then you must also get a PPD test prior to initiating therapy, because the PPD test is going to stratify whether or not you have latent TB. And if you have latent TB, you don't want to give a TNF-alpha inhibitor because that is going to cause you to have a bad granuloma, or the granuloma essentially cause you to have disseminated tuberculosis. So hope that is going to be helpful in terms of explanation. Remember that colchicine is going to be a microtubule inhibitor. And this microtubule inhibitor we use for gout. We also use for pericarditis. But what's high yield for us to know is similar to ketorolac for both answer choice A and C, you want to watch for your kidney function in the vignette. In particular, if you get an elevated creatinine in the vignette, the things that you do not want to give to these patients are nephrotoxic agents. So let's go through this. If you see a very elevated creatinine, do not pick things like vancomycin because vancomycin is nephrotoxic. Do not pick IV contrast because that also is going to be nephrotoxic. Do not pick something like giving a lot of NSAIDs or colchicine. And that's because these are going to be very nephrotoxic agents that are frequently assessed on NBME questions. All right, very good. Let's go ahead and go through this question. With adherence to the medication regimen, this patient is at greatest risk of death from which of the following? We have a follow-up evaluation of a middle-aged male who recently was hospitalized for community-acquired pneumonia, found to have new diagnosis of HIV, who now presents with a CD4 count greater than 200, has an elevated plasma HIV load, and has negative STD testing. With adherence to the medication regimen for HIV, this patient is at greatest risk for which of the following? A, cardiovascular disease, B, chronic kidney disease, C, HIV-related malignancy, D, non-HIV-related malignancy, or E, opportunistic infection. What do you think is the best answer here? Excellent. If you are saying the answer choice that is most related to metabolic syndrome, you are absolutely correct. Best answer is going to be A. So what's high yield for us to know is that both HIV therapy and second generation antipsychotics, let's say, for example, like olanzapine, both of them are going to cause you to have a predisposition to metabolic syndrome. You can get things such as lipodystrophy, which is a redistribution of fat. With HIV and some of these antipsychotics, this metabolic syndrome can lead to atherosclerosis and then subsequently to cardiovascular disease. What other agent can at times lead to metabolic syndrome? If you said chronic steroids, you're absolutely correct. Recall in the last question, the patient was on chronic steroids, prednisone, for the rheumatoid arthritis. So now I'm going to ask you to recognize this illness script. I have a patient who has autoimmune disease on chronic steroids who goes to the OR and has refractory hypotension. What is the likely diagnosis? What is the likely diagnosis in a patient who has refractory hypotension and is on chronic steroids? You got it. And if you're thinking of the mechanism of hypothalamic adrenal suppression, adrenal insufficiency, you're absolutely correct, is the likely diagnosis. And the next best step in management, besides fluids and vasoactives, give fludrocortisone or hydrocortisone. We need to give mineralocorticoids, what we call stress dose steroids, prior to or during the OR course. So I hope that this is helpful. If you guys are learning something, go ahead and give me a smile in the chat box. Say yes, everything good. Victoria's loving it. All right, wonderful. 250 students right now. You are a part of a community of future physicians, and your future patients are so lucky to have you. Let's stay active and engaged and continue with this next question. Which of the following is the most appropriate initial step in management? You have chronic difficulty sleeping and poor job performance in a middle-aged divorced woman who now presents with injected conjunctiva and dark circles around the eye. Which of the following is the most appropriate initial step in management? Education of sleep hygiene, mirtazapine therapy, sertraline therapy, setting a date for smoking cessation, or zolpidem therapy. What do you think is the best answer here? Excellent. So this patient, for lack of a better term, looks like me post-call, has signs of sleep deprivation. And so when you are thinking about the initial management, education on sleep hygiene, making sure electronics are not on bed, that's the big one now, right? getting to bed on time. These are all of the very important lifestyle changes. And as you know, there's a theme in USMLE land and even clinically that we start with lifestyle changes before we start therapeutics, such as zolpidem, for example, is a non-benzodiazepine sedative. It is going, mirtazapine is going to be a atypical antidepressant that is going to also increase appetite and even be a sleep aid. Sertraline therapy takes 6 to 8 weeks, and we have no other signs really of the full SIGA caps. Also recognize that when you're thinking about a patient who has injected conjunctiva and other life stressors, you're going to be thinking of substance abuse issues. And with the injected conjunctiva or injected sclera, you're going to be also thinking of marijuana use as well. So just something for you to screen for, especially when you see sleep abnormalities as well as multiple life stressors. Excellent job here. Let's go ahead and go through this question next. Which of the following is the most appropriate step in diagnosis? We have subacute, rapidly progressive confusion, decline in activities of daily living, and restlessness in a middle-aged female with history of diabetes who now presents with startle myoclonus, hyperglycemia, and poor recall. What is the most appropriate next step in diagnosis? Hemoglobin A1C assay, CSF 1433 protein concentration, beta amyloid concentration, methylmalonic acid concentration, serum angiotensin converting enzyme activity, or F, serum protein electrophoresis. And if you're saying that this is going to be a rapidly progressive dementia with myoclonus, and you are thinking of spongiform encephalopathy, which is Creutzfeldt-Jakob disease, it is a prion disease. You want to measure a protein that is very highly specific for Creutzfeldt-Jakob disease, which is 1433 protein. And remember, majority of these patients are even diagnosed on autopsy with the spongiform gross pathology and microscopic pathology of the brain. So acute, rapidly progressive dementia, you want to be considering prion-based diseases. And I don't know if y'all follow me on Instagram or whatnot, but I put this as an integration because I felt super inspired by this question. But if you have not yet followed HyGuru Prep on Insta, you know where to get the most nerdiest content, but that is relevant to saving lives. Determination of hemoglobin A1C concentration, that is going to be diagnosis of diabetes, type 2 in particular. Measurement of beta amyloid concentration, that's your Alzheimer's. MMA concentration, that's your B12 deficiency. Serum ACE activity is going to be sarcoidosis. And SPEP is going to be multiple myeloma. But again, we notice that one of the key illness scripts modifiers that make spongiform encephalopathy or Creutzfeldt-Jakob disease super specific is the startle myoclonus. Very high yield for us to know. Oh, nice. Mayur, thank you for following me back in the OG days. That's great. Which of the following is the most appropriate next step in management? We have acute, severe, bilateral foot pain, status post ice water immersion in a young woman who now presents with cyanosis of bilateral toes. Which of the following is the next step in management? A, place the feet in front of a dry space heater. B, rub the feet with a steaming hot towel. C, submerge the feet in a moderately warm whirlpool. D, wrap the feet in room temperature wet to dry dressings. Or E, just observe. So here we have the illness script of acute frostbite Remember that the cold nature can cause you to have cyanosis of the bilateral toes because you are going to get vasoconstriction, and that causes you to have decreased perfusion. And as you have decreased perfusion, you are going to have blueness to the toe. What's also very high yield for us to know is that you want to do moderately rapid rewarming. And that's why sticking the feet in the warm whirlpool, 37 to 39 degrees, is going to be very important. One of the other high yield questions is remove wet socks. That's super high yield for us to know, because what is super high yield is the fact that for both questions, due to chemical spills, as well as organophosphates, as well as hypothermia, they love for you to know that if you're in the ER, rip off their clothing, because that can be a source for perpetual, in this case, hypothermia. So I really want to emphasize this point here, and the best answer is going to be submerge the feet in a moderately warm whirlpool. All right, let's go ahead and go into this question right here. We have acute gum bleeding and unilateral knee pain in a middle-aged woman with lupus who now presents with friable gums, petechia on upper extremities, a joint effusion, anemia, and moderate thrombocytopenia. What is the most appropriate next step in management? Factor replacement, methotrexate therapy, plasmapheresis, prednisone therapy, or splenectomy? What do you think is the best answer here? Awesome. So the illness script here is going to be what? Is going to be ITP. ITP presents with moderate thrombocytopenia, and you are going to have systemic symptoms. Another differential diagnosis besides ITP is to also recognize that this could be a lupus flare. Remember that lupus, you get autoantibodies that can cause you to have leukopenia, low hemoglobin, as well as thrombocytopenia. So whichever the case is, in this case, the patient is symptomatic. So prednisone therapy reduced the autoantibodies that are crushing the platelets, causing you to have disorders of primary hemostasis, such as petechia. Now, this joint effusion is most likely due to lupus. However, a differential to think of when you have this kind of joint effusion in the setting of moderate thrombocytopenia is going to be hemarthrosis, because you have a tendency to bleed. However, the illness script with ITP, typically ITP does not give you hemarthrosis. And so recognize that when you have thrombocytopenia, key things for us to know is you've got more mucosal bleeding and petechia. So this unilateral knee pain is most likely due to a lupus arthropathy. Remember that hemarthrosis is going to be very characteristic of the illness script of hemophilia A or B. And in hemophilia, you have issues not of the platelets, but you have issues with the coagulation cascade, and that is going to be secondary hemostasis. And that's why factor replacement therapy is the mainstay for those patients. All right, very good. Which of the following is going to be the most likely diagnosis? Acute progressive fatigue and exertional shortness of breath in a teenage boy who recently experienced a viral upper respiratory tract infection. The patient now presents with tachycardia, tachypnea, tachycardia even more, hypotension, hypoxemia, bilateral crackles, S3 gallop, high-pitched holosystolic murmur at the apex. Which of the following is the most likely diagnosis? A, glomerulonephritis, myocarditis, pneumonia, rheumatic fever, or SLE? What is the best answer here? All right, very good. This is a high yield presentation of myocarditis. Now, this is what I mean, everyone, of taking the data points within a vignette and characterizing what is the content knowledge or what is the illness script that this is activating. For example, bilateral crackles, S3 gallop, and tachycardia should be very characteristic of cardiac failure. Whenever you are going to think of myocarditis, typically there is going to be a prodrome of viral symptoms and then cardiac failure. And that is very characteristic of your myocarditis. Again, with this viral prodrome, you could get pericarditis, which can present as sharp, pleuritic, or inspiratory chest pain. That can then be complicated by pericardial fluid and tamponade. Or in this case, it is the myocardium that is messed up, and thus you have less pump function. And why do you have a high-pitched holosystolic murmur? That is because in the setting of cardiac failure, the mitral valve annulus is going to be stretched. And if the mitral valve annulus is stretched, you can get mitral regurgitation because the heart is kind of like dilated and not as well functioning. So the leaflets are going to separate. So answer is going to be myocarditis. Treat this kind of like heart failure more than anything. And then, you can consider steroid therapy, IVIG, etc. But typically the USMLE just wants you to recognize the presentation of myocarditis. Next question. Which of the following is the most likely diagnosis? What are we doing now, guys, with diagnosis? Activating an illness script. Hyperacute bilious emesis in a full-term breastfed neonate born via spontaneous vaginal delivery who now presents with fever, tachycardia, tachypnea, weight loss, and a distended, tender abdomen. Which of the following is the most likely diagnosis for this bilious emesis? Duodenal atresia, intussusception, meconium ileus, necrotizing enterocolitis, or intestinal volvulus. What is the best answer here? Excellent. So this question is going to be a little bit challenging, and I intentionally wanted to put some teaching points here. Don't worry too much about the right answer. On the free 120, the answer was volvulus. However, I want us to really stratify when it comes to bilious emesis. What are the various differentials? Well, first off, pathophysiologically, bilious emesis by definition means that there is some issue post second portion of the duodenum. And if there is some issue post second portion of the duodenum, that could be things such as duodenal atresia, which is failure of recanalization of the gut endodermal tube. It could be at times intussusception, but that typically presents after a prodrome viral illness that then causes you to have a Peyer's patch hyperplasia. It could also be due to Meckel's diverticulum, but essentially that gives you more colicky abdominal pain. Meconium ileus, this is typically not going to give you bilious emesis as much as lower GI obstruction, which is a failure to pass meconium and a microcolon as a result of the mucus that is going to be at the terminal ileal junction. And necrotizing enterocolitis typically is going to cause you to have feeding intolerance and is associated with prematurity. And what we notice here is that this baby was full term. So I agree, it could be duodenal atresia and volvulus. Imaging is also going to help us here. Remember that volvulus is twisting of the bowel, and it's usually due to malrotation. And so what you want to get is you want to get a KUB initially to start. Remember that the KUB in duodenal atresia gives you a double bubble. So make that to answer choice A. In volvulus, it can even give you the coffee bean sign, in which you are going to get twisting of the small bowel itself. So that's answer choice E. And then remember, in necrotizing enterocolitis, you can get pneumatosis intestinalis, which is going to be a air within the wall of the tissue in the small bowel. So KUB, sorry, is kidney, ureter, bladder. It's an abdominal X-ray. I apologize, and thank you for the clarification. That is exactly how the USMLE goes for it. Clinically, people are going to say KUB, essentially focused on the abdominal region. Okay. So another thing that you want to do besides an abdominal X-ray is you want to do an upper GI series, because in the upper GI series, if you see the malrotation, then you know what exactly you're going to have to do. In either case, you're going to probably go to surgery. So hopefully this was a very nice representation and explanation. And one of the things that I want you all to recognize is that they rarely will put abdominal X-ray and upper GI at the same time. It's like, no, you're not going to do really a CT scan. You're going to start with some of these bedside type of tests. So getting in the PICU, we can get a abdominal X-ray pretty quickly, and then stratify our differential from here. All right. Only a couple more questions left. Let's go ahead and take a deep breath. Everybody doing okay? All right. Very good. I hope that this is helpful. Thank you all for joining me today. Let's go ahead and get through the remaining questions that we have here today. All right. Very good. Which of the following is the most appropriate next step in management? Subacute complaint of, quote, legs giving out and falls in a middle-aged male with history of myasthenia gravis, who recently stopped taking pyridostigmine therapy, who now presents with tachypnea, hypophonic voice, ptosis, and diffuse muscle weakness. Which of the following is the most appropriate next step in management? Assess medical decision capacity, EMG and nerve conduction studies, involuntary hospital admission, oxygen therapy by nasal cannula, or pulmonary function testing. What do you think is the best answer here? Excellent. If you are saying A, assessment of medical decision capacity, you are absolutely correct. If you think about it here, first off, the patient, yes, is going to have a chronic condition. And with this chronic condition, the goal here is to first assess whether or not the patient can make autonomous decisions. Maybe this patient with myasthenia gravis does not have further treatment as part of the goals of care. I mean, they recently stopped taking pyridostigmine therapy. So the point here is that you want to first, while the patient is in front of you with these chronic conditions, and I agree, it would be different if they are literally in a trauma or some other type of situation. Which of the following is the initial step is medical decision capacity, and that's super high yield for us to know. This patient with tachypnea, hypophonic voice, ptosis, and diffuse muscle weakness is probably not buying them nasal cannula, is probably buying them intubation. Remember that myasthenia gravis is going to be autoantibodies to the nicotinic acetylcholine receptor. And so mainstay of treatment is going to be acetylcholinesterase inhibitors. And these acetylcholinesterase inhibitors are going to increase the amount of acetylcholine at the synaptic cleft or at the neuromuscular junction, and thus are going to overpower the antibodies and improve the weakness. What is high yield for us to know is that with myasthenia gravis, you can get bulbar symptoms, and bulbar symptoms means that you are going to get issues with cranial nerves. So that's high yield for us to know. The weakness is going to get worse with activity, and Similar to Guillain-Barré syndrome, this is a neuromuscular weakness condition that can lead you to respiratory insufficiency, respiratory acidosis, and the USMLE wants us to also note that in those situations where you are going to get respiratory failure and you are getting decreased negative inspiratory forces, a very positive number in the sense that these patients are indicating that they have bad FVC, bad FEV1, they're going to have a poor inspiratory force. All of those should point you to the next best step in management, which is intubation, and that's high yield for us to know. The most appropriate next step in management is administration of which of the following? Let's go ahead and get it here. Acute unresponsiveness and confusion in a middle-aged male with history of substance abuse and major depressive disorder who now presents with hypothermia, hypotension, hypoglycemia, and elevated blood alcohol content. The most appropriate next step in management is administration of which of the following? D50, flumazenil, lorazepam, naloxone, or thiamine. What is the best answer here? So in patients who are going to have confusion, substance abuse, and very elevated blood alcohol content with hypoglycemia, before you give the dextrose, you want to give thiamine, and that is extremely high yield for us to know. Remember that thiamine is going to be key in order to process the glucose that you're going to give. So thiamine deficiency is seen in alcoholics, and these patients can present with confusion, ophthalmoplegia, and ataxia. And that is going to be your Wernicke encephalopathy. They can have confabulations, and that's the Korsakoff syndrome. Remember that patients with thiamine deficiency can also present with beriberi, and you can get a presentation of heart failure with wet beriberi in particular. So why is thiamine so important? Recall, and I know you guys probably think I'm a big nerd, I'm sorry, but recall that in glycolysis, you need the glucose to be broken down, and pyruvate, which is the end product of glycolysis, then needs to be put into the TCA cycle as acetyl-CoA. And remember, the enzyme pyruvate dehydrogenase needs thiamine as a cofactor. So no thiamine, no metabolism or processing of glucose. Pyruvate can even shunt to lactate, and you can have things a little bit worse in this situation as well. So before you give the dextrose, give the thiamine in that area as well. Flumazenil is going to be for benzodiazepine overdoses. Lorazepam is going to increase the amount of GABA, and we use lorazepam for sedation as well as seizures. And remember that if I put that this patient has a respiratory rate of 6, then you should activate the illness script of opioid ingestion. And so if I say opioid ingestion, what would be in the vignette for physical exam? Go ahead and type that into the chat. What would be the key pertinent positive in the vignette? And if you're saying meiosis or pinpoint pupils, you are absolutely correct, along with maybe even a blood gas that you get after you physically examine them with respiratory acidosis. Guys, this is why I think PICU is just one of the best fields in the world, because we get to see all of this. This is application of science helping those around you. It's just so beautiful. This is the stuff that you get assessed on. I will tell you, we do see it clinically as well. So forget the naysayers that are like, oh, it's just an exam, pass it, move on, etc. No, spend the time to kick ass with this exam because it makes you a better doctor. That's for sure. All right. Which of the following is the most likely diagnosis? Acute, severe, unilateral scrotal pain in a sexually active teenage boy, who presents with moderate edema, diffuse tenderness to the hemiscrotum, and a nice key pertinent positive, absent unilateral cremasteric reflex. Many of you have activated the illness script, but I'm going to ask you, what is the next best step in diagnosis? What is the next best step in diagnosis? Yeah, ultrasound of the testes with Doppler. Yeah, exactly. Or ultrasound of the scrotum with Doppler. And then you want to call the urologists. Even if it's 2 in the morning, we have to call them because they will need to do a detorsion, or they may fix the testes into the scrotum as well. So just things for us to really keep in mind is the recognition of the fact that if you are going to have testicular torsion, the spermatic cord is going to torse, and within the spermatic cord, you have the nerves. And as you have the compression of the nerves, that then is going to cause you to have a decreased cremasteric reflex. And so the best answer is going to be testicular torsion. Sorry about that, guys. Testicular torsion. Remember that the epididymitis could have been an answer choice because of the sexually active teenage boy and the diffuse tenderness in the hemiscrotum. However, the illness script of epididymitis typically does not have a absent cremasteric reflex. Testicular tumor usually is a painless testicular mass. Seminomas are most common. Torsion of the appendix of the testes. Remember that that is going to cause you to have a little bit of a pinpoint bluish hue to the scrotum, and you get plus or minus cremasteric reflex in that. But true torsion is where you get the absence cremasteric reflex. And remember, varicocele, very high yield for us to know, varicocele does present with a tender scrotum. However, it is not going to be torsion of the spermatic cord as much as a dilation of the veins in the scrotal region, which is the pampiniform plexus. And varicocele, remember, is going to have a classic finding that is A, number one, very positional, and B, the pain is going to improve when you are going to elevate the testes. And so, yes, bag of worms appearance, varicocele, very high yield. Few more questions, guys. We got this. Imagine this. In just about an hour, we are going through a block of questions, plus also we are going through the explanations. All right. After discussing the implications of this diagnosis and poor prognosis with the parents, which of the following is the most appropriate next step in management? We have acute facial droop, difficulty walking, headache, and double vision in a young, previously healthy boy who now presents with bilateral 6 and 7 cranial nerve palsy, ataxia, and MRI notable for diffuse intensity of the pons. So in this situation, remember that this patient is having signs of a brain tumor, compressive symptoms, and the child is having headache and compression of cranial nerves and ataxia, and the MRI is going to be notable for a diffuse interpontine glioma, and that carries a very poor prognosis. So what is going to be the next best step? Discuss goals of care for the patient. Everyone, do you see this theme? Even with the myasthenia gravis question, this is what we do day in and day out in the pediatric ICU, making sure we are in alignment with the child's wishes and the substituted judgment that loving parents have. That's very high yield for us to know. So the best answer here is going to be discuss the family's goals for this patient. All right, very good. Which of the following is going to be the most likely diagnosis? Chronic facial rash, shortness of breath, with exertional non-productive cough in a middle-aged woman who now presents with chest x-ray consistent with interstitial markings and hilar fullness. Which of the following is the most likely diagnosis? Rosacea, sarcoid, seborrheic dermatitis, systemic lupus, or scleroderma? What do you think is the best answer here? Excellent. As you can note, the facial rash, the differential for this facial rash, lupus for sure, rosacea. Remember, in rosacea, they even say that it is like a oily rash with telangiectasias. And then you're going to also be thinking of sarcoidosis. These are inflammatory states or inflammatory conditions. But now with the pulmonary symptoms, the highest yield diagnosis here is going to be sarcoidosis. Remember that if you are going to get a biopsy of the hilar lymphadenopathy, you will see the non-caseating granulomas. And remember, the USMLE loves for you to know that these non-caseating granulomas have 1-alpha hydroxylase activity that takes 25 vitamin D and turns it into 125 vitamin D. And that's extremely high yield for you to know. Remember that another key consideration is to recognize that, yes, lupus can cause you to have the rash, but lupus gives you mucosal findings. And these mucosal findings are oral ulcers like aphthous ulcers. You can also get pericarditis or pleural effusions. And remember that systemic lupus has a lot of serositis associated with it. Systemic sclerosis, typically, that is not going to have a rash. Systemic sclerosis is going to have primarily increased fibrous tissue. And that increased fibrous tissue can be everywhere, definitely can be within the lungs, but the USMLE loves for you to know that it could be fibrous tissue within the renal artery, and that can cause you to have hypertension with severe features and hypokalemia in patients as well due to activation of RAS. All right, we have only 7 more questions left to go. You guys doing okay? Everybody all right? Excellent. Azka, Victoria, Carrie Ann, Rogelio, Ravinder, Claire. Nice to see everybody. Let's take a deep breath. I will tell you, at Prometric, doing this physiologic sigh is going to help you. It's going to recenter you. Prometric day is going to be a grind, but if you visualize, if you prepare for it mentally, you're going to do absolutely phenomenal and wonderful. Let's go ahead and go through this. Measurement of which of the following is the most appropriate initial step in diagnosis? We have subacute severe pain and generalized muscle weakness in an elderly male with hypercholesterolemia, hypertension, and myocardial infarction. Basically, how do I paraphrase all of this? Atherosclerotic risk factors. As a pediatrician and pediatric intensivist, I don't really see much atherosclerotic risk factors unless kids have dyslipidemias, but that's an aside. This is an elderly male with atherosclerotic risk factors controlled on statin, clopidogrel, lisinopril, amiodarone. Let's go ahead and do an MOA rapid review. HMG-CoA reductase inhibitor, P2Y12A receptor blocker, or ADP receptor blocker, ACE inhibitor. Amiodarone is going to be a potassium channel blocker that can cause you to have systemic symptoms. This patient presents with diffuse proximal muscle weakness. One of the key test-taking strategies that I will tell you is whenever they are going to give you 3 or more medications within a vignette, think about drug-drug interaction, like CYP interaction, or you have to be thinking about an adverse drug event, because usually the USMLE wants you as a future doctor to look at a list of medications and say, do you know some of the side effects that can occur? And so the best answer here is going to be CK activity, because this patient most likely has statin-induced myopathy, and that's high yield for us to know, especially if the patient is going to have this generalized myalgias. Remember that amiodarone, you have to monitor your LFTs because it is hepatotoxic. your TFTs, which is your thyroid function tests, and your PFTs, because amiodarone can cause you to have pulmonary fibrosis as well. All right, let's go ahead and go through this question. After the stinger is removed, which of the following is the most appropriate next step in management? We have acute pain at the site of a bee sting in a young military male who now presents with stable vital signs, swollen area of induration on unilateral cheek, and swelling in the lower aspect of the orbit. After the stinger is removed, what do we want to do? Inject epinephrine, admit to the hospital for IV vancomycin therapy, cleanse the site, and apply ice, obtain an ophthalmologist consultation, or prescribe oral clindamycin. What do you think is the best answer here? Yeah, and you guys are hitting it right on the money, where you want to be thinking of least invasive to most invasive. So cleansing the site and applying ice is going to be key. So again, bee sting, and if I change this to unstable vital signs, yes, you're going to be thinking of anaphylactic shock. One of the underappreciated symptoms that they put with anaphylactic shock, besides urticaria or hives and shortness of breath, is GI cramping. The USMLE wants you to know that like a systemic histamine reaction can cause you to have severe GI cramping. And that's where IM epi is going to be the treatment of choice. The induration of the unilateral cheek and swelling is going to be the rubor, calor, dolor, tumor, signs of acute inflammation. Now, if there was pus coming out of that area and you notice that some time has passed after the bee sting and there's concurrent infection, then you need to be doing IV vancomycin therapy. Remember that these patients can actually get cavernous sinus, thrombitis, or thrombophlebitis. And that's super important for us to know, because essentially the bite was in like the danger triangle that has direct extension into the cavernous sinus, and that can cause clotting and cranial nerve dysfunctions and proptosis as well. So super high yield for us to keep in the mind whenever there's any sort of pimple popping or bee sting in this area. Cavernous sinus thrombosis, again, proptosis is going to be one of the highest yield illness script modifiers for you to think of. Let's go ahead and go through this question. After removing all firearms from this patient's house and admitting him to a psych facility, what is the most appropriate next step in management? We have acute on chronic, severe depression, poor self-care, refusal to eat, auditory hallucinations, and suicidal ideations in a young male with refractory severe depression who now presents with minimal verbal responsiveness, auditory hallucinations, and a desire to die. What is the next best step in management with this acute severe depression, ECT? Remember, the reason why you don't do sertraline therapy is because it takes 6 to 8 weeks for the patient to get to a steady state of the sertraline and for it to kick in. Another key thing for us to know is that ECT would be indicated in patients not only in this condition with severe depression, but also maybe even in pregnant patients who are unable to start SSRI or any sort of antidepressant therapy. ECT for acutely homicidal, suicidal pregnant patients is also going to be a key illness script and question to keep in mind. Screening for which of the following is most appropriate in this patient? We have routine health evaluation in a middle-aged, non-smoking female with history of hypertension, asthma, and normal colonoscopy and pap smear. She had it at regular intervals, and those are fine. She now is undergoing screening. What is going to be the next step in management? Do you get a AAA screening, breast cancer screening, STI screening, colon cancer screening again, or Hep C infection? Excellent. This is a good question. I think there could be multiple answers based on this specific illness script. I may have to go back to the original vignette in the free 120. But what is important for us to note is that patients who are going to be greater than the age of 18, one time you do a hepatitis C screening, and that's the best answer. You're absolutely correct that breast cancer screening starting at the age of 40 is going to be important for us to keep in mind, and that's going to be yearly mammography and extremely high yield. Remember that colon cancer at the age of 45 and at 5 or 10-year intervals, depending on what the initial colonoscopy is going to find. So again, these are high yield questions for us to know. Yes, you got it if you are going to be doing mammography at a yearly interval and one-time hepatitis C screening for all patients greater than the age of 18 is also a very high yield USPSTF guideline consideration. All right, very good. Let's go ahead and go into this next question. Which of the following is most appropriate to prevent recurrence of these symptoms if the patient is diagnosed with strep pharyngitis again? You have acute follow-up in a school-age female recently treated with penicillin for strep pharyngitis, who now presents with, here we go, fever, morbilliform rash, urticaria, and diffuse arthralgias with lymphadenopathy. Labs note leukocytosis and UA significant for proteinuria. Which of the following, after antibiotic therapy, you got all these symptoms, what are you going to do to prevent this recurrence? Give an antihistamine, pre-treat with the corticosteroid, skin testing with a penicillin derivative, use of a non-penicillin antibiotic, use of a single injection of benzathine penicillin to treat the pharyngitis. What is your best answer here? If you can also provide me in the chat box, what is the specific illness script? That is also going to be very helpful for you to incorporate. What is the illness script that this question is testing you on? Excellent. This is the illness script actually of serum sickness. So in serum sickness, this is a type 3 hypersensitivity reaction in which you are going to get the penicillin acting as a hapten, and you are going to get antigen antibody deposits that then is going to cause you to have diffuse inflammation, fever, rash. The fact that the patient can also have lymphadenopathy, that's also a very characteristic finding of serum sickness. And why does the patient have a proteinuria? Well, yeah, maybe they're dehydrated or something, but the most important mechanism is that the antigen antibody deposits go into the kidney and are going to deplete your complement. And that's why you can get a damage to the glomerulus and proteinuria. So the best answer, if patients are going to get serum sickness, let's say to penicillins, this is kind of an allergic-based reaction, but it's more so a type 3 hypersensitivity rather than a type 1. The best answer is do not give penicillin antibiotics, and you may want to think twice before also giving other beta-lactams like the cephalosporins as well. All right, very good. Couple more questions. Here we go. Which of the following is the most likely diagnosis? You are not going to give up at block 6 on your exam, are you? Pretend this is block 6. You got this. Chronic, rough, painless lesion on unilateral hand in an elderly farmer who now presents with a solitary 2-centimeter lesion on the dorsum of the right hand, which has recently increased in size and has central umbilication. So a progressive rash in sun-exposed areas that is painless. What are you going to be thinking of? And if you are saying a keratoacanthoma, You are absolutely correct. If you want to even Google image, what is a keratoacanthoma? It is going to be this circular lesion, and you're going to have keratin debris in the center of it. It can actually increase in size and is associated, similar to actinic keratosis. Keratoacanthomas are going to also be associated with squamous cell carcinoma, and that's high yield for us to know. Remember that it can be in patients who have a lot of sun exposure, and that's important. The central umbilication is going to also be seen not only in keratoacanthoma, but in pox virus. Typically, this is going to be in pediatric patients with molluscum contagiosum. You also want to recognize that the transmission of that is fomite mediated, and pox virus, interestingly, is also going to be associated with HIV. So this is extremely high yield for us to know that this is a precursor kind of lesion to squamous cell carcinoma, and the fact that it is going to be having that rapid expansion growth that is characteristic of keratoacanthoma. Which of the following is the most appropriate next step in management? Here we go. You have routine health examination in a young 37-year-old non-smoking, previously healthy male with obesity who now presents with hypertension. So we have risk factors here: hypertension, obesity. What are you going to do next? Occult blood, CBC, TSH, lipid, or have him go his merry way? And that is going to be serum lipid studies, doing metabolic screening in these patients. All patients greater than the age of 30 are going to get a one-time. But if you are greater than the age of 20 and you have risk factors like family history, hypertension, obesity, you're going to get those serum lipid studies a little bit lower. So remember that you want to be testing comorbid conditions with metabolic syndrome. Which of the following is the most appropriate next step in management? Acute persistent fever in a young hospitalized female with type 2 diabetes, currently admitted for pyelonephritis, on ciprofloxacin therapy, who now presents with fever, tachycardia, tachypnea, borderline low normal blood pressure. This is what I like to call compensated septic shock. She's almost there, but she has enough cortisol, norepinephrine, epinephrine, counter-regulatory hormones, maintaining her vasoactive tone. Physical exam is consistent with CVA tenderness. What do you want to do in this patient? Do you want to add Clinda, add Vanc, CT scan of the abdomen, Doppler ultrasound, or repeat blood culture and add fungal cultures as well? What do you think is the best answer here? Now, what is high yield for us to know is that this patient has extremely important persistent fever and is undergoing treatment for an infection. What is key here is to note that the patient most likely doesn't have a concurrent MRSA infection or whatnot, but the USMLE wants you to know that whenever a patient is going to have persistent fevers while being treated for an infection, you have to be thinking about abscesses. So usually an infection is going to be treated with antibiotics. However, if the body is walling off the infection and you get that thin rim of epithelium, the antibiotics cannot penetrate. And this is such an important concept for you to know because it ties in histology, that the antibiotics cannot penetrate the simple squamous epithelium of the abscess. And so the best answer here is get a repeat scan as the patient has persistent fevers. And the next best step in management after that is drainage, because they love for you to know this specific term and tell this to all your attendings and your ID doctors. Source control is so important in infection. If you can say source control, when I'm on rounds, if some resident or fellow says, treat the underlying cause, I'm like, oh my gosh, amazing. you want to really make sure that you get source control in the setting of abscesses and potential septic shock. Which of the following is the next appropriate next step in management? We're almost done, guys. Hang in there. Acute refractory hypotension in a young male with cystic fibrosis admitted for septic shock secondary to critical pneumonia, now requiring, stay focused, intubation, sedation, broad spectrum antibiotics, who now presents with tachycardia, hypotension, status post 4 liters of normal saline, has inspiratory crackles, and an ultrasound showing IVC caliber with minimal respirophasic collapsibility. The patient also has persistent lactic acidosis. What is the next best step in management? A, administration of 1 liter of normal saline. B, administer IV hydrocortisone. C, administer IV voriconazole. D, continuous infusion of norepinephrine. Or E, order a head CT. I want to spend some time on this question. Is it okay, everyone? May I spend some time on breaking down this question, because there are so many pearls in this question. And being an intensivist, this is my very, I love these kind of questions, because I see these questions on my boards, except, young male. Yeah, it's a pediatric patient. All right, here we go. So acute refractory hypotension, that means that you are going to be in very severe shock. It's refractory. The patient has gotten 4 liters of normal saline, and still the patient is not having an increase in the blood pressure because they have hypotension still. This is where you want to consider beginning vasoactive therapy. What's also high yield for us to recognize and note is the fact that this patient has signs relatively of fluid overload. After giving so much fluid, the patient is having inspiratory crackles, indicating that there's a lot of fluid within the lungs. So you don't want to keep giving more fluid. Remember that if you look at the SVC or the IVC, typically, if you are going to be hypovolemic, you are going to have on inspiration collapse of the SVC or IVC. And so what we notice here is that in this situation, the patient has no collapsibility, indicating that the central venous pressures are so juicy. What else is going to cause you to have increased amounts of central venous pressures? Well, intubation, because intubation causes you to have an increase in intrathoracic pressure. And that increase in intrathoracic pressure reduces a preload because it causes less of a gradient of flow between your caval circulation and your right atrial pressure. So what is important for us to recognize is that this patient still is in shock. So you have to deliver oxygen. And so whenever a patient is hypotensive in front of me, blood pressure is going to be equal to cardiac output times total peripheral resistance, also known as systemic vascular resistance. And if this patient has critical pneumonia, maybe is a little bit immunocompromised with the cystic fibrosis, or at least can get opportunistic infections like from Pseudomonas, et cetera, and they're going to be very hypotensive in the setting of septic shock, their SVR is low. So when their SVR is low, they are going to have extravasation of fluid from the intravascular space into the tissue space. So that's why initially you want to optimize preload and get more blood within the vasculature. And so that optimization of preload can optimize your stroke volume, and that can optimize your cardiac output. But what we recognize is that this patient is having signs of fluid overload. So you don't want to keep giving fluids. You want to tighten up the systemic vascular resistance by giving alpha-1 agonist, which is going to be norepinephrine. Alpha-1 agonist, norepinephrine also has beta agonist activity as the dose increases as well. So if the patient is going to be on high dose norepinephrine, maybe you added vasopressin as well to get more vasoconstriction. Then you would give stress dose steroids in fluid refractory, vasoactive refractory septic shock. That's where you're going to try to give hydrocortisone. And I'm going to stop the diatribe now, but hopefully this explanation integrated various components such as recognition of shock, what to do as the next best step if you have refractory hypotension, cardiovascular physiology, and a little bit of biochemistry, because lactic acidosis indicates that you either have too much metabolic demand or decreased oxygen delivery, and you're switching the pyruvate to anaerobic metabolism, and that is going to be via lactate dehydrogenase, and you're going to get an anion gap metabolic acidosis, which you can see on your blood gas consistent with lactic acidosis. Three more questions. Let's go. The patient is at greatest risk for developing which of the following? Chronic irregular menses and impaired glucose tolerance in an obese, nulligravid woman who now presents with elevated fasting serum glucose. Which of the following is this patient most at risk for developing? Gestational diabetes, hypothyroidism, IUGR, placenta previa, or preterm labor? What do you think is the best answer here? Well, if she has dysglycemia, best answer is going to be gestational diabetes. Remember that preterm labor, the number one risk factor for preterm labor actually is going to be prior preterm birth. Other minor risk factors, things like hypertension, things such as low socioeconomic status, if you are going to have a teenage pregnancy, these are all going to be associated with preterm labor. But if you came into the pregnancy hyperglycemic and have dysregulation of your glucose or metabolic syndrome, most likely you may have consideration of gestational diabetes. And remember, we screen patients around 24 to 28 weeks with oral glucose tolerance tests for the screening of gestational diabetes. Which of the following is the most likely diagnosis? Subacute progressive swelling and shortness of breath in a middle-aged type 2 diabetic woman who recently was treated for UTI and initiated on lisinopril, who now presents with tachycardia, hypertension, diffuse crackles, S3 gallop, pitting edema, and a BUN to creatinine ratio that is going to be 45 divided by 4 is almost 10 to 15 is to 1. UA is also significant for low specific gravity. Which of the following is the most likely diagnosis? Glomerulonephritis, acute interstitial nephritis, acute kidney injury, acute obstructive uropathy, or intravascular volume depletion. What do you think is the best answer here? Excellent. Very good. If you're saying acute kidney injury, you are absolutely correct. Recognize that this patient was initiated together with amox probably or something, antibiotic plus lisinopril, and lisinopril can be nephrotoxic at times. The patient is also going to have signs of fluid overload. When your kidney or your heart or your liver doesn't work, you're going to retain fluid. Your kidney is supposed to help you pee out fluid. No kidney, no fluid regulation, so you can get fluid overloaded. Your heart is supposed to pump out fluid. If you have bad heart, you can retain a lot of fluid. Your liver is supposed to give you that oncotic pressure to keep a lot of the fluid within the intravascular space. And thus, similar to nephrotic syndrome, if you have low oncotic pressure, you are going to retain a lot of fluid. So this patient has signs of fluid retention and is going to have a reduced concentrating ability of the tubules. And so acute kidney injury is the best answer. Remember that acute interstitial nephritis is going to have a subacute tempo, could be associated with a trigger such as amoxicillin, could also give you 10 to 15:1 or intrinsic AKI. But remember, acute interstitial nephritis key is eosinophilia, hypertension, and a rash. And these are all of the key features or the illness script of acute interstitial nephritis. So the best answer here is intrinsic AKI. All right, I think we have 2 more questions and we are done. Who is ready to be done with this session? We still got 200 people. Only 10 people have logged off. And if you've made it to this part, I'm going to give you a big hug right here. You guys are crushing it. Thank you so much for staying and being a part of such a wonderful family. Group hug. I like that, Rogelio. Very nice. Don't want it to end. Learning a lot. Oh, thank you. All right, let's go for it, guys. Oh, this is the same one. So I think we have one more question left. Yes, one more question left. Last question. Which of the following is the most likely underlying diagnosis? Acute unilateral leg pain after a fall in a teenager who is a refugee, who has a history of prior fractures, bilateral hearing loss, and family history of skeletal abnormalities. This refugee patient with recurrent fractures now has decreased height, kyphosis, hypermobile joints, and right lower extremity tenderness, indicative of probably yet another fracture. What is the underlying diagnosis? Go ahead and spend some time putting in what you think the illness script is. Last question. As you guys go through this, I want to tell you that when I went through those last 10 questions on step 1 and step 2, it's like so emotional. It's like, man, home stretch. You spent so many hours studying for these exams. And hey, this is the last question for today. Please don't get emotional. If you do, it's okay. We're all friends here. Excellent. If you're saying osteogenesis imperfecta related to the fact that this patient has multiple bone fractures indicating that collagen 1 formation may be poor, remember that the hearing loss is due to the fact that the malleus, incus, and the stapes may not be formed as well. With osteogenesis imperfecta in children, you want to also rule out non-accidental trauma, but recognize that the blue sclera is more so consistent with osteogenesis imperfecta, and the exposure of the choroidal veins is extremely high yield for you to know as a mechanism behind osteogenesis imperfecta. Patients who are going to have osteogenesis imperfecta are going to have normal calcium, phos, and alkaline phosphatase. Whereas if you have osteomalacia or rickets, remember that those patients are going to have a vitamin D deficiency. So their alk phos is going to be elevated, and their calcium and phos, because they don't have active vitamin D, is going to be low. Remember, juvenile Paget's disease, that typically is not going to present with sensorineural hearing loss, or is not going to present with these recurrent fractures like you're seeing. And juvenile osteoporosis, again, these are relative distractors, as they are relatively zebras, and the illness script with the family history is also very important to recognize. And that's why it's not idiopathic. This is definitely something hereditary and genetic. Very key for us to also note the differential for hypermobile joints. You want to be thinking of Marfan's, Ehlers-Danlos. Remember, Ehlers-Danlos is going to be a joint dislocation rather than recurrent fractures. Remember, Ehlers-Danlos syndrome classically is an issue with CoLA5 or type 5 collagen, where this one is more type 1 collagen. And yes, you can get the hypermobile joints, but there are recurrent fractures, the blue sclera, as well as the sensorineural hearing loss that is more characteristic in this situation of osteogenesis imperfecta. Hopefully, this was quite the webinar. I would encourage you all to just clap for yourself and stick around for just a couple minutes. I want to also do a Q&A, but I wanted to also let you all know that I teamed up with Med School Bro, and we created a website called chatgptusmle.com. So definitely check that out. It has a bunch of prompts already for you. So if you want to use ChatGPT in your USMLE studying, just trying to be innovative as possible. Step 1 pass-fail course, as well as my rapid review Step 2 CK course. Definitely check it out. More question breakdowns and integration in that review for the Step 2 CK course. And with that, I want to encourage you all to have a great rest of your day. Best wishes with your studying. If you guys are able to, just fill out your feedback for my resources or this session. Feel free to just spend a few minutes sharing this session on Instagram. Also, if you want to write a review, my goal is to help medical students one student at a time. I don't do any gimmicks or anything like that. Hey, listen, I'm here to serve you all. So your feedback as I improve is so key. And so definitely check my social media out. Follow me on Instagram, subscribe to me on YouTube. And before you leave today, finally type in one thing that you learned, and I will see you all in the next Tutor with Me breakdown block session. Excellent. 6 weeks out, first pass of UWorld. I would go ahead and do a second pass of UWorld if I were you. Excellent. Source control is going to where the infection site is. Crackles, cardio overload, don't give more fluid. I like that. I learned how to better identify shock. Fatima, thanks for joining. Kabiru, thanks for joining as well. Excellent.